When we talk about this, I mean, you folks here see it every day. You folks here actually see it kind of at the end point. And I feel a certain sympathy for the folks out there in the real world who are in their offices, the frontline physicians, and they see all comers. First there's a pregnant woman, the next there's somebody with strep throat, and next comes somebody who says, I can only walk 18 holes a day. So what did the frontline docs need to know? What is their takeaway on diagnosing this and caring for this?
So I think the interesting thing for physicians is that normally we like to see something and then we like to treat it, or we like to refer it to a specialist for definitive treatment. Unfortunately, in osteoarthritis, that treatment is going to span a large amount of the life expectancy of that patient. So when they're first diagnosed, if they exhibit the symptoms that Paul was speaking about, that they have discomfort or stiffness or pain or a disability associated with an activity, we need to rule out the other problems that could be associated with that, inflammatory arthritis, et cetera. Those are done with some simple lab tests. But if an x-ray is taken and osteoarthritis is seen on the x-ray, the typical spur formation, narrowing of the joint space, deformity of the limb alignment, and the primary care doctor or the frontline doctor can treat that patient with simple conservative measures, physical therapy, over-the-counter anti-inflammatories, ice, heat, small braces, et cetera, that's great. If the patient needs more than that, they should refer them to an orthopedic surgeon, a rheumatologist, a specialist in osteoarthritis, who then can decide if there's further imaging necessary. Most imaging is only necessary if they have another set of problems such as instability.
So, yeah, Peter, I'd like to emphasize what Rich said. You know, often we see patients referred from primary care physician with MRI scans and they've not had plain radiographs. And one take-home message to the primary care physicians who are watching this is if you're going to order some imaging, get a standing x-ray first.
Weight-bearing x-ray,
yeah,
correct.
Why weight-bearing? Why?
Well, because sometimes you won't pick up narrowing of the cartilage of the knee joint in a supine or non-weight-bearing film.
And I would even push that one step further to say that what I do in my practice is actually get single-leg weight-bearing exercises, because unless you're a kangaroo, you walk on one leg at a time. And the bottom line is that that's the physiologic functional test that you can do very easily to know what's happening with your patient.
So if you take the load off, as I understand this then, if you take the load off the joint, then the joint can get a little larger and look better?
In advanced osteoarthritis of the knee, you know, if it's bone on bone, I'm not sure the non-weight-bearing x-rays are going to be a lot different. But, you know, it's very interesting. I don't know what it's like in the Northeast, but in the South, most of the internists are not even ordering x-rays. They're referring the patient on, you know.
Does that make any sense?
It depends on the insurance model, right? It depends on whether they're in a capitated system or some sort of a system that dissuades them.
You'll forgive me. Let's take money off the table. Clinically, does it make sense to not get an x-ray and say, oh, your knee hurts, go there?
I think the rationale is that you're thinking you have 30 seconds to make a decision as a primary care physician, and you have a patient with knee pain. You want to get the maximum information for a single test. Unfortunately, when you get an MRI, it's like looking at an elephant under a microscope. Until you sort of pan out and say, okay, what are we really looking at here? With a plain x-ray, with a good physical examination, you don't really have a sense as to what to do with all that information you get with an MRI. And that's the problem, whether it's economic or intellectual or clinical, that we find ourselves in when a patient presents with an MRI, but no basic information.
Well, I think we're going to get into this in a little bit, but I think for the primary care physicians, you know, if they're pushed, if the patient is not that disabled, you know, maybe they can just go to the, you know, what the non-surgical treatments we're going to talk about first, and then if that patient doesn't respond, calls the office again, then get an x-ray and then refer.
Part of the issue with getting the advanced imaging before you get the primary indicated imaging is there are a number of diagnoses associated with an MRI, and with osteoarthritis of a knee that may not need to be treated as the primary issue.
Absolutely.
For example, an MRI may show a meniscal tear. It may show degeneration of the anterior cruciate ligament. It may show cartilage damage. It may show loose bodies. If the patient doesn't have symptoms associated with those diagnoses, they're not going to need surgical intervention. But once that diagnosis is told to the patient without context, it becomes a real issue, and the internist isn't really capable of making that clinical decision. So, for example, every single osteoarthritic knee, okay, after a time has a torn meniscus, all of them, whether it's degenerative or not. The trick here, and what we get paid to do every day, is to figure out which of those symptomatic ones need treatment in a different way. And that's a very difficult decision.
So we come back again to being a doctor and not a technician, right? That the MRI, in my experience, is a great tool. It sees everything, but sometimes everything is not what you need. Or to quote Dr. McCoy, I'm just an old country doctor, Jim.
That's right.
Maybe I just need an x-ray or a good history in physical.
Well, I think contextualizing the information that you get from any clinical study or any clinical exam is really what it's all about. And that really goes back to basics, you know, the introduction to clinical medicine. Take a history, do a physical exam. You'll be able to make the diagnosis 85% of the time, and an x-ray is confirmatory. You don't really need to go beyond that in a primary care setting. And I feel bad for the primary care physicians because listen, 50% of patients with knee osteoarthritis are treated in that space, in the primary care space. But by the time they get done in their 15-minute appointment talking about hypertension and diabetes and cardiovascular disease and risk modification, and then, by the way, they got the hand on the door and the patient says, oh, by the way, my knee's been bothering me. And they, well, you know, it's either an MRI or some Tylenol. So those are the two decision things.
Right, but I think the key for the, you know, sometimes the primary care physicians are under pressure. The patient says, I want an MRI. They saw that on Law and Order, right? The patient had an MRI, so I need one. And then they come to the surgeon and say, I need an arthroscopic surgery because my MRI showed that. So again, I think the take-home message for the primary care physician is resist the pressure to order an MRI before a radiograph.